Hello and welcome again to the radiology portion of your Digestive 2 module. Today we're going to talk about radiologic diagnosis and treatment of acute gastrointestinal bleeding. I'm sure you'll be disappointed to learn that this is one of the shorter lectures that you'll get from me, but try to contain your disappointment and bear with me. And again, I think the objectives are fairly specific and should help you with your studying. The only lecture I'm going to signpost to today is Dr. Malik's gastrointestinal hemorrhage lecture. Dr. Malik goes into all kinds of different causes for gastrointestinal hemorrhage. We're not going to worry about the causes in this particular lecture that I'm giving right now. This is to tell you how we diagnose gastrointestinal bleeding and how we can treat it utilizing radiologic techniques. So we'll let Dr. Malik deal with all that, the causes, the etiologies of gastrointestinal bleeding. So one of the first things I want to say is that radiology does not have much of a role in diagnosing or treating gastrointestinal bleeds that are proximal to the ligament of Treitz. Okay, so everything in the esophagus, stomach, and duodenum is not really has a good role for radiology in it. Now we can see bleeding in these areas, but it's a lot quicker and a lot easier to put down a nasogastric tube and to get a gastric aspirate. And if the gastric aspirate is positive, then you know you have an upper GI bleed, or for the purposes of this discussion, we'll describe upper GI as proximal to the ligament of Treitz. Those are handled by endoscopy with cauterization or selective drug vasopressive substances. So if a patient comes in with a gastrointestinal bleed, put down a nasogastric tube, aspirate. If it's bloody, call a gastroenterologist or a surgeon who does endoscopy. If not, if the gastric aspirate is normal, that's when you call radiology. So radiology should be reserved for bleeds distal to the ligament of Treitz. For the purposes of this discussion, we'll call that lower GI bleeding. So the primary tool in our arsenal to detect gastrointestinal hemorrhage or gastrointestinal bleeding is the technetium-99m autologous tagged red blood cell bleeding scintigram. Technetium-99m is just the radioactive component. We attach that to autologous, or the patient's own, red blood cells. And then we put the patient under a camera and evaluate the radioactivity that's coming out of the patient, and that's what the scintigram refers to. Again, we should only be doing this if the nasogastric aspirate is negative for blood. If it's positive for blood, they need an endoscopist. The good thing is that we don't require very much bleeding at all for a red blood cell scintigram to be positive. We can detect down to 1/10 of a mil per minute of bleeding within the distal small bowel, the jejunum, the ileum, or the colon. And the reason it's useful is this way we can direct the angiographer and or the surgeon on where that bleeding is, and they know where to put the catheter or where to do the surgery. This is very sensitive. 95% sensitivity, 93% specificity. That means that if there's a bleed there, we're going to see it 95% of the time. If we think we see a bleed, that's going to actually be a bleed 93% of the time. And that gives us an overall accuracy of 94%, which is pretty darn good. I wish my car decisions when I buy a car worked out 94% of the time. So this is a good study for detection of lower GI bleeding. And what we do is there's a process involved in this. We use what's called an in vitro method. And the reason we do that, it's the more complicated way to tag red blood cells. But one of the things that concerns us is that if we have technetium-99m running around in the bloodstream and it is not within the red blood cells, that free technetium is excreted by the gastric mucosa. And so we get a hot area within the stomach, and we can have a false positive. We can think that that is a gastrointestinal bleed, an upper GI bleed. And so what we want to do is have a high labeling efficiency. That is, that when we incubate the red blood cells and the technetium-99m, that 95% or greater of that technetium-99m will be within the red blood cells. And so what we do is we withdraw blood from the patient and spin it down in a centrifuge, pipette off that buffy layer, the white cells in the serum. And then what we do is we incubate what's left, the red blood cells and the platelets, with stannous chloride. Now, stannous, if you'll recall, not the stannous that's in Game of Thrones, but the other stannous, is tin. Okay, so this is called tinning the red blood cells. What the tinning does is it's not actually tinning the red blood cells, it's tinning the technetium-99m. It is reducing the valence state from +7 to +4 of the technetium-99m. You don't have to remember that at all. I don't really care about it. I don't like chemistry. I don't care if you know it. But for you chemistry nerds, the +4 valence state is much easier for that technetium-99m to cross the red blood cell membrane. And then once it gets in the red blood cell, that tin dissociates, the stannous chloride dissociates, the technetium-99m reverts back to the +7 valence state, and it can't recross that cell membrane. So it's trapped in the red blood cell, which we like, because we don't want, once we get that in the red blood cell, we don't want it flowing back out and becoming free within the bloodstream anymore. So we tin the red blood cells, and then we incubate these with the technetium-99m pertechnetate, and then we wash them with some of the reserved plasma and re-inject them into the patient. This whole thing takes about 20 to 30 minutes. Now that may seem like a long time when the patient is actively bleeding, but you have to remember it takes a while for these patients to get kind of packaged up, put on a gurney, get all their IVs and their blood or whatever, if they're receiving a transfusion, onto the gurney and get them down to the radiology department. And so usually what happens is when an order is dropped by the floor or by the emergency room, one of our technologists will go up to the floor or up to the emergency room, draw the blood, bring it down, do the tagging of the blood, and usually by the time the patient gets down there, the tagged red blood cells are ready to be injected. So what we then do is put the patient under a gamma camera and image this patient for usually 60 minutes. If we don't see a bleed by that time, then we can go another 30 minutes or so. By 90 minutes, everybody's tired of it. The patient's tired of it. We're tired of it. It's not very high yield, so we usually send the patient back if they don't have a bleed. If the patient has a brisk bleed, then we can terminate the study at any time. And usually what happened, at least where I worked, was the floor or the ER would do simultaneous orders. One order would come to us to say, please do a tagged red blood cell scintigram. Simultaneously, an order would go to angiography that says, basically, if the tagged red blood cell scan is positive, please do angiography for diagnosis and treatment. And so if I saw sometime during the study there was an active bleed, then I would call the angiographer in and I would go over it with him and discuss where it was, how fast it was going, and all that. And Then I would just keep the patient under the camera until angiography was ready for him. If they were ready for him right then, we'd get the patient on a stretcher, get him into angiography. There's no reason to take it out for 60 minutes if we see the bleed a lot earlier. Now, we can do delayed imaging up to 24 hours after injection. And so we have a patient under there for 90 minutes. We don't see anything. We send them back to the floor. They have another bloody stool. 12 hours later, 24 hours later, we can bring the patient down and re-image them. The problem with this is that we are looking to guide the angiographer or the surgeon as to the location of this bleed. If we do these delayed views, generally what's happened is that bleeding has already gone throughout the bowel. It's collected in the dependent portions of the bowel, or the portions that are lowest when the patient is lying down, and we have no clue where the bleed came from. Nuclear medicine imaging is fairly expensive. We wouldn't have to charge them again for the technetium 99M, but you charge them for the camera time and all that type stuff, and there's really not much reason to do that. You can save a couple $1,000s and just do a guaiac test, which costs a few cents, rather than the $1,000 or $2 of delayed imaging of the nuclear medicine. So that's why I say we refer to these as the world's most expensive guaiac tests. We really tried to discourage this where I worked. In fact, anytime a clinician would order this, we would call them ourselves, and generally end up convincing the clinician it was unnecessary and unlikely to yield useful results. We had one guy that would never accept that. He always wanted delayed images, and we did them for him. But anyway, it probably should not be done on a routine basis. Okay, so here's a gamma camera. This is one head of the gamma camera. There's a big crystal in here that detects these radiating waves that come out of the patient. The technologist will move this camera down right to just above where it's almost touching the patient, and the patient will lie there as we image. So this is what a normal gastrointestinal bleeding study looks like. Basically, we see blood where we're supposed to see blood. We don't see blood where we're not supposed to see blood. Now, these can look kind of confusing since you're not used to them. Each one of these images is actually a stack of images kind of added together. This is from 1 to 3 minutes, from 4 to 6 minutes, from 7 to 9 minutes, and so forth. But we see blood within the aorta, within the iliac vessels. This kind of diffuse, increased, darkness is just blood within the cascades to the bowel. But it looks like the blood kind of elsewhere within the abdomen. We do see the stomach, which we would like not to see, but that doesn't really worsen through time. It doesn't go anywhere. That's just that free technetium being excreted by the gastric mucosa. If we were up a little higher, which we normally are, we might see a little bit of the liver and a little bit of the spleen as well. Now, one thing we do see is this down here. This can be confused for a gastrointestinal bleed if you're not used to looking at these studies, but this is actually the penis. The penis is very vascular, and it's also a trick that we nuclear medicine docs like to pull on unsuspecting residents, especially radiology residents, saying, gosh, look at this. Are we sure there's not bleeding in the sigmoid colon, the rectosigmoid? And the correct answer would be no, it's in the penis, and we can tell that because the blood just kind of comes here and it stays there. It doesn't go throughout the bowel. It just sits right there where the penis is. Now, this is an abnormal bleeding study. Again, we see blood in some of the normal spaces that we would expect to see red blood cells in: the aorta, the iliac arteries. We see a little bit of the liver, maybe a little bit of spleen. I'm not sure we really see much spleen. Kind of seems to be peeking out behind this 30-minute mark. We do see, again, the penis. This is not a rectal bleed. This is the penis. But what we also see is we start seeing, even at the 5-minute interval, this kind of little blush beside the aorta. And as we go out to 10 minutes, we start seeing this blush taking the form of small bowel. And as we continue the study, this progresses more and more through the small bowel, and we would expect to see that with blood. We would expect blood to move through the small bowel. Now, it can move antegrade, but also because blood is very irritating, it can move retrograde too, so don't let that fool you. On this patient, by the 10-minute interval, or at least by 15 minutes, but probably by the 10-minute interval, I would have already called the angiographer and said, okay, this guy's positive. Whenever you're ready, come over and take a look, and then you can take the patient whenever you need to. But you see, even at the 60-minute interval, this is, throughout pretty much all of the jejunum, maybe starting to get into the ileum. Now, one thing that's available to us now that has not been available for very long is CT angiography. CT angiography can be very useful, especially if you don't have a nuclear medicine department in your hospital, or if nuclear medicine is not very available. Say the technologist is an on-call technologist, it's 2 a.m., they live 45 minutes away, it's going to take them a half hour to get ready, 45 minutes to drive in, another 30 minutes to tend the patient, and another 10 minutes or so to get the room set up. So in the meantime, you could have had this patient on and off the table on CT angiogram. Again, CT angiography requires an active bleed, and it's not quite as sensitive as red blood cell scintigram. We need, instead of 1/10 of a mil per minute, we need about 1/2 of a mil per minute to see it on CT angiography. So the sensitivity is less, about 86%. So if there's a bleed, we'll see 86% of them with CT angiography. Specificity is pretty much the same, 95% to 93%. There's a small risk of contrast-induced nephropathy or contrast reactions and allergy to contrast, but it's no greater risk than any other time we give CT contrast. This is a CTA of the abdomen, CT angiogram of the abdomen in a patient with cecal hemorrhage. And these are just a few selected slices, but what we've done is we've not given the patient any oral contrast. We don't want to give oral contrast because that would obscure the intravenous contrast in this case. And so we have intravenous contrast. We can see the contrast within the aorta here. And we see during this arterial phase, we see contrast within the lumen of the cecum. So this is a gastrointestinal bleed. That's the only thing that really would cause that, as long as the patient hadn't swallowed some metal or something. This is a gastrointestinal bleed. And if we do a coronal image, then we can see this bleed starting to progress through the abdomen. And if you look up here at the top of this loop of bowel, it almost looks like there's contrast spraying out of a nozzle or something. And that's pretty much what's happening. That contrast is spraying up there. And this is something we see sometimes when we have bleeding, a brisk bleed from the bowel or from a broken bone or something like that. We can see this kind of spray effect. This is a little bit later in the cycle. This is called the venous phase because we now see the aorta and the inferior vena cava are about the same density. And we see, if we do a transverse section, we still have contrast within the cecum. And now we can see that this contrast is starting to pool here in the hepatic flexure. The patient has been lying on his back, and so the hepatic flexure is posterior. It's dependent, and so this is where the contrast collects. This is one reason why with the scintigram, we don't like doing delayed images because contrast tends to collect in these areas, but we see where this is actively bleeding here. So this is a positive CT angiogram for cecal hemorrhage. Okay, one of the things that everybody thinks of when talking about radiology and gastrointestinal bleeding is selective angiography or selective arteriography. And the reason we call it selective is because we want to get as close to the bleed as we possibly can. We don't want to just do a angiogram of the aorta with all the runoff vessels, or even a superior mesenteric angiogram in which we might get obscuration of the point of bleed. If we see a bleed in the jejunum, we want to select jejunal vessels. If we see a bleed in the ileum, we want to select ileal vessels, and so on. Now, again, this requires an active bleed. All three of our studies require active bleeds, and this is even less sensitive. So we need, depending on who you read, 0.5 ml per minute to 1.5 mils per minute to really see the bleed. Now, this makes a sensitivity of 46%. That's not very good. Specificity is good. If we see the bleed, we're pretty sure that that's really a bleed. But sensitivity, we're seeing less than half of these GI bleeds just with kind of random catheterizations. And that's where the scintigram comes in useful, because a positive scintigram increases successful angio rates by 22 to 53%. And so this will increase this rate significantly if we can tell the angiographer where this patient is bleeding from. And so that's the purpose of the CT angiogram. There is a chance of some complications. Of course, we have the renal failure and the contrast reactions that we have anytime we give a patient contrast, and we have that problem. We can also get arterial embolisms, dissection of the vessels, and subsequent ischemic bowels. But luckily, serious complications are pretty low on this. It's an involved procedure, but it's not a hugely dangerous procedure. But the reason that this is so useful is that we can positively treat a gastrointestinal bleed within that same session. And what we do is we find the bleed, then we can go in, through the same catheter that's already there and inject something like vasopressin, or inject some coils or gel foam or something of that nature to cause embolism of that artery, so that artery can no longer supply the bleed. Okay, and so this is a jejunal catheterization, jejunal artery catheterization. We see the catheter extending up the aorta into the superior mesenteric artery, and it's now at the branch of one of the jejunal arteries. When we inject contrast, we see contrast within these tubular vessels. They keep branching until they're just kind of string-like or thread-like. But we also see this stain that doesn't really belong in a vessel. And that's because it's not in a vessel. This is extravasation of contrast into the jejunum. And even as we are now starting to get some clearance, just because of regular blood flow, we've stopped injecting and we're clearing out some of these jejunal branches, but this stain persists. Now, all of these branches have been cleared out, but we still have this contrast within the lumen of the bowel. And if we watch it, it should continue on down the bowel, just like the scintigram, the red blood cell scintigram did. So now that we have this here, we have this catheter already within the artery that's supplying this, we can embolize this. They can put coils in there, or they can put vasopressin, and this is what that looks like. Now he's done the embolization, he's pulled back the catheter so it's in the proximal superior mesenteric artery. This jejunal artery was somewhere down in this area, and we no longer see that jejunal artery. And we don't see that stain from the bleed. So we've had a successful embolization of a jejunal bleed. And you might think that the patient is at risk for ischemic bowel, and occasionally that can occur, but for the most part there's enough collateral vessels that, especially if we can get as close to that bleed as possible, then there's not a lot of risk of ischemia. There's a little bit, but it generally works out pretty well. Okay, this is an algorithm I took from Dr. Malik's lecture. I shamelessly stole it because it's pretty good. If a patient comes in with a bleed, do a nasogastric aspirate. If that's positive, call the endoscopist. Okay, so that's easy. If the nasogastric aspirate is negative, but the bleeding's very mild, the patient doesn't have much bleeding, they're not in acute distress, they can be prepped for an elective colonoscopy. And so they can go through the whole colonoscopy preparation, usually 2 days or a day of clear liquids, and then the night before they take stuff to just make them evacuate their bowels and clean out their bowels, and they can undergo an elective colonoscopy. For moderate bleeding that we don't want to send the patient home, we can do a tagged red blood cell scintigram, or we can do an urgent colonoscopy. And by urgent, it still is not emergent, because it still takes time to clean out those bowels, and we will aggressively get them to aggressively enemize the patient and give them purgatives and laxatives and try to clean out that bowel. But it still is going to take 4 or 6 hours to get the bowel cleaned out, and it's not a very efficient method. Whereas with technetium red blood cell scintigram, we don't need to clean out the bowel. Now, the one area where I will kind of part ways with Dr. Malik is with life-threatening bleeds. I would say not to go straight to mesenteric angiography, but go ahead, bring the patient down, do the scintigraphy like we said. Doesn't take that much longer, and it gives such a better outcome for the angiographer that I think that's usually a much better way to go, rather than the angiographer going in and having to spend a lot of time blindly catheterizing vessels. Okay, and that's it. You see the minions are clapping because it's a much shorter lecture, but we will see you next time, and happy studying.